So because these questions come from a number of different sources, we may go back and forth between topics. First question, I'm going to direct to Ms. Salters. When we were discussing devolution, the evidence, both in the report and orally, was to the effect that the health departments in Scotland, Wales and Northern Ireland would often follow the lead of the Department of Health in Westminster. Do you have any sense as to whether that was a conscious decision or a result of inertia?
I think it's a very good question. I suspect the answer varies from subject to subject. The instances that I'm directly aware of, which don't relate to the subject matter of this inquiry, were, I would say, mostly conscious decisions.
The next question is directed to whoever might know the answer, which is this. What do the panel know of freedom to speak up champions within NHS bodies?
In terms of how successful they are, I don't know how much. Certainly it's taken seriously. Somebody fairly senior has the role. I wouldn't like to say across the NHS exactly how it's functioning. And I think if it's the right person, I'm sure it can be useful. But I don't, in terms of what they do day to day and how much, you know. But again, the fact that you've got somebody who might be a senior and trustworthy person, I mean, that in itself is important. And I suppose potentially that's someone to whom, you know, people can go if need be. But in terms of how it's operating in practice, I wouldn't like to say that I knew.
And do you know whether it's a role that is present in all four nations within the United Kingdom?
I don't.
And then this, I think, probably still to you, Professor Vincent. We talked about the role of patients and their families, and your report talks about involving patients and their families. What role can patient representative groups, including charities, play in policy development within the health service?
In policy development, I think Michael and Claire would know. It depends what we're meaning by policy. If we're meaning government policy, then I'll let Claire, perhaps also Michael, say something about that. But I mean, charity groups of all sorts of kinds play a very important role. I mean, certainly for researchers, you know, it's enormously important sometimes for funding, sometimes to collaborate with patient organisations, you know, who are developing new treatments, whether they're biological or changes to services. And I'd like to think it would be great if the NHS organisations could make more use of patient charities, because I think it's a fantastic way, an efficient way, if you like, of accessing what I would call sort of patient expertise, because I think the critical thing always in these is to ask, you know, whether it's me or you or what kind of expertise do we have as a patient that health professionals don't have? And often that's quite specific, and the patient charities are obviously a particularly rich resource of that. I mean, it's a very general answer, but...
I mean, I'd like to think the pandemic was a pivotal moment. I mean, what happened during the pandemic was that people turned to charitable groups, to voluntary sector organisations, rather than the statutory sector. And why did they do that? Because those groups were more trusted, which the public sector, which I spent my life in, should reflect upon. They were more agile. They could change the way in which they were delivering the service more quickly than the statutory sector could. And I think that we haven't, in the statutory sector, whatever words we've used, we have not, I think, valued the voluntary sector as much as we should. We've not treated them as proper partners. Too often, I think, local government, I've spent a long time in local government as well, local government has seen them as a cheap way of delivering services, rather than seeing them as true policy partners sitting at the table when you're designing policy and designing how you deliver them. So I think this should be a pivotal moment, and the voluntary sector should be much more respected, much more valued, and much more involved than it has in the past.
Can I just say too that there's examples too, especially independent patient advocacy charities, that sort of thing, of signalling when it's important to refer to them at the very least in design, but also signalling where things may be going wrong. So if you take AFMA, for example, in the duty of candour, they highlighted the adoption of the organisational duty of candour, but that enforcement mechanisms were weak or non-existent or not being pursued, and that provided an impetus for the regulator, being the CQC, to perhaps, you could argue, contribute towards them taking a more proactive role. So seeing them as co-sharing in leadership, I think in terms of what Professor Vincent identified in terms of shared leadership and partnership. Also, if you've got patient groups where they're representing their members who have a lifelong or chronic disease, their experience of the health system and health professionals and the organisation would be valuable in that regard. So seeing ways in which that is integrated on a more ongoing basis is useful.
Next question is for you, Professor Farrell. The duty of candour. We've talked about the NHS. I asked about central government and whether that should be subjected to a duty of candour. Arm's length bodies associated with the NHS or with the Department of Health, should the duty of candour extend to arm's length bodies who often have a very important role to play in the delivery of healthcare services?
I think that's a very interesting question, and I know that arm's length, and I would also defer to Michael and Claire to see what they would say about how arm's length bodies are set up. Are you talking about executive agencies, for example, that may have a connection to healthcare?
As an example,
so
certainly.
I know they've undergone various iterations under the UK government, for example, in terms of their reach and their independence, and whether they come, for example, within the Department of Health or are seen independently. I mean, at the heart of a duty of candour is the need to be open and honest with your constituency. So I suppose you have to look at their regulatory remit to see where that's permissible or whether it should be permissible. But if your constituency is particularly referable not only to clinicians but also to various patient populations, then, you know, at the heart of the duty of candour is a need to be open and honest and to learn from what you're hearing in that context. So, but again, I'm mindful of the fact that it depends on the arm's length bodies.
And then the next question is probably, again, in the first instance to you, Professor Farrell, but for wider contribution if desired. Your report refers to, and we've touched on, the numerous inquiries and reviews which have made year after year similar recommendations that might suggest that learning and change is not being embedded in the NHS. Are there any specific statutory or regulatory levers that might assist in ensuring that organisations learn better from their mistakes?
Just as a general principle, I suppose as a default position, there can be perceptions when things go wrong or harm is caused. There's often recommendations for policy and law reform that may be the panacea. If we only pass new laws, new regulation, then that will address the harm that was caused, or perhaps prospectively look towards better accountability in the future, for example, or better reforms of redress. Now, while law, and law can take many forms, from the criminal to the civil to the administrative to the regulatory, does have its role in terms of changing ideas, norms, and standards and the ways in which we do things. The question is, and the lessons learned from those multiple inquiries, I would suggest, is that reform on its own is a good thing in terms of norm setting. But if we learnt anything from, for example, duty of candour, for example, is that ultimately they set the standards, but you need the embedding of a cultural change, of a behavioural change, and that's much more long-term. So the levers, I think, are well established from a range of inquiries. We can add to it, whatever, but there needs to be a political commitment, a resourcing commitment, as well as a capacity on the part of regulators to be resourced and to take action in the area. Often they have quite substantial powers to do so. So it's keeping that in mind. What I would also say too is that, and I think COVID has brought this out somewhat dramatically as well, is that in acting in that regard, we need to take account of complementary laws in relation to both equality and human rights that have particular importance for patient groups and particularly marginalised patient groups and those who may feel disadvantaged. And that as we exercise levers in the legal sense, that we appreciate these complementary legal levers in redressing harm.
Can I pick up something we haven't talked about much in the last 2 days, which I think is really important? There is sometimes a sense that you can improve and change organisations through inspections and inquiries. I'm sorry about this. My view is that by and large, it's limited. You change organisations, you improve things through the quality of leadership, and I don't just mean by one person, but the leadership team within an organisation. The 7th of the Nolan principles is about leadership, and I think we need to be developing a cohort of leaders across government, but across the health service, who are progressive and thinking about how you set the right culture, how you deal with risk, how you manage risk, and how you deal with failure, and how they send the right messages out to the rest of the organisation. Because at the end of the day, the organisation will follow the leader or the leadership. They will do what they think they want, and too often the message is not clear enough.
Next question arises out of the discussion we had earlier about the communication of risk by government to the public, and the question is this: in the context of a new or emerging threat, it might be said it's all the more imperative for there to be government guidance, government communication of risk, because the alternative would be wholesale reliance on individual clinicians to try and make up their own mind, and then a disparate response across the nation. Any observations in relation to that?
So I think it's a very good point, especially in a world of social media where all sorts of information and misinformation will be transmitted once a new virus, for example, emerges. But I'm not sure necessarily how a government can synthesize very disparate findings, some which suggest great alarm, some of which suggest great complacency. What is the government to say other than there's a lot of views on this particular problem? I can't see how government can have a solution. It can't win in that state, even though I accept that all this information flowing around is very confusing for the population.
But Ms. Salters?
I was just going to say, I think that's valid, but for government, whether it's at the political level or the chief medical officer's level, being able to give a statement of guidance of what is known and what is the best guidance available based on what's known, even if there's an element of uncertainty, is more helpful than people on the ground trying to make it up as they go along. Even if you have to couch the guidance in terms of very little is known at the moment, we could be being overcautious, but this is what we would say based on what we know.
Professor Pollock and then Professor Powell.
Just to repeat what we said earlier, was the communication of uncertainty and the unknowns is as important as the knowns. And I think the UK has been very bad at that. It's created a lot of polarisation. And you contrast that, for example, on COVID vaccination in children with the statements made by the Norwegian and the Danish governments and Swedish governments, actually, in very stark contrast to how we've communicated risks and uncertainties and unknowns.
Professor Farrell.
Can I just say, and it's mentioned in the report, is whether we're talking about COVID, where we're talking about contaminated blood, infectious disease, sort of outbreaks, that sort of event, is the notion of preparedness. Now there'll be lots of inquiries now going ahead with COVID as to how we do that. There's public health preparedness, there's legal, ethical, human rights. But who are the groups who are most oftenly disproportionately impacted by a failure to prepare, by a failure to communicate risk or manage it? And a lot of the research points to, the same groups being affected, the disadvantaged groups, minoritized groups, those that's suffering from socioeconomic disadvantage. This is not new, but there needs to be a multi-pronged approach to prospective management under the rubric of preparedness. It's not just about stockpiling. stockpiling enough medicines, although that's very important, and enough gear, personal protective equipment. It's a holistic approach to understanding how we prepare and protect the individuals and those who are most vulnerable, as often many patients can be, from both harm but also from the risks that are likely to emerge, which we have a lot of information about already from this and other inquiries.
I just want to finish by saying, I think what we've highlighted in the report is the erosion, the fragmentation, and now the dismantling of the systems for communicable disease control. So preparedness needs to recognise that and needs to be ready to put back in place the necessary systems. We can have all the best leadership in the world and all the best cultures in the world, but if we don't have the system in place, we're going to be in the same position again.
Yeah,
and it's not enough to have leadership.
In my view, culture trumps structure every day of the week. But the point I was going to make is I'm not sure government any longer is the best form of communication of risk. You know, the days of the public information film that we sometimes see are long gone. I think the public generally are more likely to trust citizens' advice, age concern, people like this, than they are government or the NHS locally or nationally.
The next question is to you, Lord Bichard, and it's just, I want to go back to an extract from the transcript yesterday when I asked you a question and then just split it up into two separate scenarios. Lawrence, could we put that page back up on the screen? So if we pick it up, thank you, bottom right-hand corner, I asked you, Lord Bichard, this, and I'll just read out the passage and then ask you the question. If we then assume there's an issue that's being brought to the attention of the Minister, one of the areas the inquiry's been exploring is when evidence from or recommendations from, say, expert groups are presented to the Minister in such a way that they receive a consensus view, so they are, if we just go to the next bit, told, well, this is the way the ultimate recommendation of this expert committee is, and the Minister's not told about what might be dissent or minority opinions. And then your answer was that that was a big problem, it's tantamount to misleading a Minister.
Yep.
And what I want to do is split up my question into two scenarios and see if your answer applies just to the first or to both the scenarios. So the first scenario is where you have a committee recommendation, but with a dissenting opinion, a dissenting view recorded in that committee communication. Would it be right to understand from your answer yesterday that dissenting view should be passed on to the Minister for the reasons you gave yesterday?
Yeah, normally I would say that's the case. You've got to look at the particular case.
Yes,
right?
understood.
But in the sense that ministers ought to have as much information as they can in order to make the decision, then if there's a dissenting opinion, they should have it. And the ministers, the best ministers I work for, would be absolutely incandescent if they found out afterwards that this had been kept from them.
And then the second scenario, and it's just slightly different from the first, you have a committee, there are a range of different views and expert views expressed in the course of the committee's deliberations, those are recorded in the minutes, but then there is a consensus recommendation at the end.
Yeah.
Would you have the same view about that, where the Minister is told only of the consensus view at the end, because it is a consensus, and is not told that, however, a range of diverse views have been expressed in the course of the deliberations?
If it was me, I would say, well, there is a consensus view from this committee, but that's been reached after a wide-ranging discussion. There are different views that have been put on the table. I'd try and summarise that very quickly. But I wouldn't leave a minister unaware that this is contentious territory.
Okay, we can take that down, thank you. The next question is probably for Lord Bichard or Ms Salters. If a new government has an incidental change of principal civil servant, I can't think what was in the mind of the person putting forward this question, is the new civil servant barred from considering the outgoing government's papers as much as new ministers are barred?
No, they're not. But you have to be careful not to explain that difference in a way that could be used by the incoming minister to criticise the former minister in a political sense.
And then next question also for either you, Lord Bishop, or Ms Salters. Is a minister entitled to seek expert advice outside of the civil service system?
Absolutely.
Yes.
Next question, I think, is probably for anyone on the panel who has a view, although it arises out of, I think, of the discussions that I was having with Professor Vincent in particular. Should there be a new and independent patient advocacy service, a properly resourced patient advocacy service as part of the NHS across the United Kingdom? Professor Vincent, and then I'm going to ask Professor Farrell.
Presumably you mean in the sense of a single national organisation or more challenged locally?
I think the premise of the question is a new and independent patient advocacy service. I think there may be different ways of delivering it, but a universal, essentially, independent advocacy service for patients.
Okay. It's certainly worth looking at. I'd have to be quite careful not just to create another organisation on top of other things. But as Alison was saying earlier, I think it would be valuable to have a proper resourced service which was capable of more challenge than currently. And, you know, there are a number of organisations and who work with best intentions, but if they're not resourced and they can't, so they aren't vocal enough, if you like, say, not through their fault, but a bit more challenge to the health service and a bit more. I think I'd like to see it not so much in the terms of advocacy of individual cases, but of a sort of collective intelligence about, really trying to get hold of what major patient concerns are in this area and communicate them quite forcefully. So the idea of not just of sort of advocating for single patients, but aggregating patient concerns in a serious manner, now that would have something to recommend it. But it would need resourcing and it would need, thought about, how to integrate what's already there.
Professor Farrell.
Yes, just back to Professor Vincent's groundbreaking work in the 1990s about what do patients want when things go wrong. Explanations, apologies, professional accountability, and that what happened to that patient or family does not happen again. So if we take that as sort of a default redress model, or how do you deal with patient complaints or concerns, I'd like to suggest that an interesting model that may be adopted in this regard, and independence has been highlighted as key, independence from the health service and from the health leadership in terms of not only investigation but follow-up and redress and dealing between patients and clinicians. An interesting model is the Health and Disability Commissioner in New Zealand. It's been identified as a one-stop shop for patients and their families who've suffered harm when they don't know where to go. It operates independent of the health service in New Zealand. They have the power to investigate, but signpost and refer on to patients and families. Also to contact clinicians where there may be a problem and see can they be referred off for further rehabilitation or investigation if there may be a fitness to practice issue. Refer on again to the no fault scheme that operates in New Zealand. So signposting, independence, investigation. So it meets those redress elements, but most importantly, and sort of fits in with the design of holding the institutions and professions to account. Now, I'm not saying it's ideal, but it fits a lot within that redress model that patient empirical research has identified as important.
Professor Armstrong.
I think I would have some concerns about a patient advocacy agency because in a way this should be a core function of the NHS. So everyone in the NHS should be aware that that is part of their job, is to think about the patient. And the dangers of taking it out of the NHS, so to speak, and putting it in a different organisation means that people can think, oh, well, somebody else is looking after that, I don't have to bother with it. So I think that unless it's very specifically defined so it doesn't remove that responsibility from everyone else in the NHS, I would be cautious about setting it up.
Ms. Salters.
And I would agree with that as a risk. I think if you are going to have such an institution, thinking about it from a devolution and geography point of view, you would either have to have replicated organisations in each part of the UK, or have an organisation that was very clearly owned by each of the 4 home nations and wasn't simply an English institution operating in an English way and dealing in a second-class, inadequate way with those not based in England.
I think it's an interesting idea. I don't think it should be seen to be owned by any of the nations. I think it should be perceived to be independent, fully independent by patients and by the public, because if it's seen to be, if they see it as being part of the NHS bureaucracy or the government bureaucracy, they won't trust it.
Next question is, I think, for you, Lord Bichard, or for Ms. Salters. I asked you yesterday about the convention that ministers do not see for example, the papers of their predecessors, the advice given or submissions given to their predecessors, in part because of the risk of political capital being made in relation to that. And my question to you yesterday and your response was in the context of there being governments of different political persuasions. Is the same convention applicable where it's a minister of the same political party who's either coming in directly following a predecessor in a reshuffle, or submissions of earlier governments of the same political persuasion?
I think, but we need to check this. If it's part of the same government, there wouldn't be a problem with them seeing the papers. But if it's from a previous administration, even if it's previous administration of the same colour, there would be a problem. But I would need to double check.
I think we need to double check that, because within parties you may have noticed that there are differences of opinion and some personality conflicts that are played out. So in that situation, it could be quite difficult. I think there's responsibility on the senior civil service, the permanent secretary, to ensure that where a problem, if you like, bridges administrations, that the incoming Secretary of State is sufficiently briefed on that, and to do it in a way that does not give them ammunition just to use it as a political weapon. And that can be done. I mean, you'd want to make sure that the new Secretary of State was fully briefed on the issue, but in a way that didn't turn it into a party political.
And in reality, that's most likely to be the useful way of dealing with things in the best interests of the incoming Secretary of State. They'll want advice that's up to the minute based on the situation as it is now and as it may have evolved in the time since the previous advice went up, rather than just say, here's one we made earlier, have a look at that they're wanting advice on what they should be doing now.
The next question, I think, is one I'll ask generally, and then whoever feels most inclined to answer, please do. It's in terms of picking up from the evidence about audits, the confidential inquiry on maternal death and morbidity, and looking at possibly another source of information, and that's inquests, and in particular coronial reports on the prevention of future deaths. Has the duty imposed on coroners by the Coroners and Justice Act 2009 to write prevention of future death reports in certain circumstances had a measurable impact on patient safety? Does anyone feel equipped to answer that? Professor Farrell.
There was an empirical research project run out of the University of Manchester that looked at coronial records for the Manchester coroner to look at whether there was learning and to look at who was advocating and what the consequences were. So our understanding of the research that was done at that time, and it is sort of it's 5 to 10 years in terms of when the data was collected, so things could have changed. But what struck us was that some patients and families were more able than others to advocate for for inquiries and for learning in the area and for inquests to happen. But also the nature of the coronial system was we observed that some coroners were more active than others in following through in terms of recommending follow-up from inquests and wanting to address that to sort of local health services arising out of fact circumstances to see whether there could be learning. So, and again, there is potential there that for learning in that regard. And I would also draw on my home jurisdiction, the state of Victoria in Australia, where it's actually statutorily mandated that any findings by the coroner, that the state government has to post online within 3 months their follow-up.
Lord Bichard, yesterday when I was asking you about the ministerial code, you said you detected no great enthusiasm for putting the ministerial code on a statutory footing. Leaving aside the absence of political enthusiasm for it, in your view, should the ministerial code be put on a statutory footing?
Absolutely I do. And let's be clear, there are different views across the political divide about this. I don't see any great enthusiasm at the moment with the current government, to be honest. I think there is more enthusiasm with other parties to turn this into a statutory code, and I think that's exactly what should be done.
And then this afternoon, I think, or today certainly, evidence touched on ministers defending the indefensible, and you've said ministers are too often drawn into doing this. Bearing in mind 3 of the Nolan principles, so selflessness, act solely in the public interest, honesty, be truthful, and leadership, does the fact that ministers are too often drawn into defending the indefensible suggest that the Nolan principles are not working?
I think in that sense they're not working as well as one would want. I think it's not just ministers, to be honest. I think it's also senior managers and senior civil servants who can sometimes be drawn into defending the indefensible. I don't think when they do that they immediately refer back to Nolan and think, oh, maybe I've not done that quite right. Because I don't think those the 3 principles you've identified have been kind of teased out sufficiently for them to realise that you are offending against them.
And last question, and again I'll direct it to you, Lord Bichard. Do you think standards in public life have improved since the Nolan principles were published?
I think it's been a sort of roller coaster in a way. I mean, I think at times they have. I mean, I'm an independent crossbench member of the House of Lords. I don't have political views, but I think things have gone up and down, really. I think the Nolan principles have had an impact. I do. And I think as we say in the report, it's not so much whether there have been sanctions applied as a result of misconduct. It's the fact that you have a very clear reference point. And you can hold people to account to some extent, sometimes in the media. If you didn't have that reference point, that would be more difficult. But I think we've identified 2 or 3 areas where we would, not just us, but I think all of us would think that maybe the time has come to have another look at these and how they're defined.
So those are the questions I'm proposing to ask from the suggestions I've received. Do you have questions for the President?
Yes, well, I have a couple. And the first, it's to each of you, because your different perspectives may matter. And it arises out of something which I think all of you have spoken about, which is the airline industry and its attitude to safety. And it also arises out of an observation you made in particular, Professor Vincent, where you described somebody, the question of whether they should be blamed or not, as being potentially the inheritor of a problem created elsewhere. And you spoke of there was talk about mixture of organisational and individual responsibility, and we came to the question of accountability. Can I give you one example to try and put flesh on this in the same way as Ms. Richards gave an example to base a question on? This is drawn from a real case, and it involved a nurse alone in a ward who was busy nursing, changing and dressing on someone who had MRSA. At the time she was doing that, a patient fell out of bed and cried out on the other side of the ward. Now, she had been told that she should wash or use the hand sanitizer before she went from one patient to another. And the hand sanitizer was there at the end of the ward beyond the patient who'd fallen out of bed. That's where it was. So, being a human being, she left the patient she had been handling, went to the patient who had fallen out of bed, and that patient, in due course, got MRSA as a, probably, one can't be sure, but probably as a result. Now, who was at fault? Where does accountability lie? Has she inherited the problems of other people? Because you might say, well, it's her fault. She did it, and she'd been told not to. She understood not to. But then she may not have been trained sufficiently to understand what the risks were and what she should do, and whether she might call for help. It may be the fault of the hospital in having insufficient staff on the ward, which may itself be a problem of resources and the inability of the various bodies to provide sufficient staffing in that particular hospital. If we are talking about accountability, we may need to ask accountability for what, of whom, for what, to whom. Where do you see the accountability there as lying, and how best should a system address that?
Sorry, I think you started in the wrong place, because what you've done is to start with the nurse. I mean, actually what you should be starting with is what's happened to the patient.
Yes.
Yeah? And you should be trying to unpack that in terms of the systems that surrounded that patient at the time. And that would cause you to ask questions about what training that nurse had been given, what guidance she'd been given. It would cause you to ask whether she should have been left on the ward on her own, and whether a hospital was putting sufficient support in for. If you get my point,
I do. Yes.
You started. I'm exaggerating for effect, please. You started by looking for someone to blame or to defend the nurse. I'm starting from looking at the incident and asking, let's explore all the things that surrounded this incident and ask whether or not there are changes that need to be made for the future to avoid that arising again.
Well, my understanding is she got the blame. So, but then the question was, should she have done?
Well, if she ends up getting the blame on, I'll shut up in a minute, then what you've ensured that no one else is going to use their initiative in that hospital in the future, because that's what she was doing with good intent. So I think you just need to be very careful not to send out the wrong signals to people who are, with good intent, using their initiative to protect a patient. We're not going to disagree for the first.
No,
feel free, entirely.
I'm pausing because I'm wondering how unpopular this will be. I think building on what Michael says, on the accountability question, I think you can sort of say, it's the sort of way people think about it, and there are kind of formal ways of doing this. Put a reasonable nurse in the same situation, what are they going to do? Probably the same thing. So it's not going to help a lot to blame. The bigger question is that I think there's often an assumption, whether it's inquiries or incident investigation, that if you can kind of tease out what happened and allocate responsibility and stuff, that in itself is going to be a useful intervention. And I would say the question of how to make the system safer is almost entirely separate from the questions of accountability. And often these are done at the same time, and actually they're entirely separate enterprises. This is similar to what Michael said, but I'm trying to put it more starkly. And it's almost as if you have to forget the past in order to think about the future. To forget, in a way, not worry about the nurse, but look at the situation as a whole and think, this kind of thing is going to arise in the future. What can we do about this? And also with the realization in this case, I think, is that no standard rule or protocol survives real life for very long. There are always things like this. And there's a hugely exaggerated hope that more standards and more rules and stuff will make us safer. And that's a big discussion. I don't want to get I'm going too far beyond what you're asking, perhaps. So, I mean, I think I'll pause on that.
Professor Pollock.
I was interested in Michael's response because he's just contradicted his response to me, where he said, in his view, culture trumps the system. But what we actually have is
I think it says culture trumps structure.
Structure, well, structure
and
for me.
I was going to point out that the system is it's neither culture nor structure. It may be, in effect, more culture than structure, possibly.
Well,
structure may set systems.
Yes. Yeah, but structure and systems are often are interrelated. And certainly from my public health training, they are. So area-placed health bodies, they're structures or organisations, and they're also the system as well through which planning works. So actually what you've just described is the way in which culture and behaviour are the products of the system or the structures as well that are in place. So I suppose my question would be, in what way is the patient experience and patient safety going to be improved by the 2012 Health and Social Care Act, the disestablishment of services from area health bodies, the abolition of the Minister's duty to provide key services throughout the country to everybody? How is that going to improve? And the stripping away of the systems for public accountability, that slow degradation that we've seen and now their disestablishment. So I think your example is a very nice one of the way in which culture and behaviour are products of the system.
I'm a bit dismayed that the nurse was held responsible there, because it seemed to me that was a very sound clinical judgment. On the one hand, there's the risk of transmitting MRSA, which presumably she's aware of, but also there's a risk of leaving a patient who is in need, who is obviously distressed, having fallen out of bed, but may have sustained severe injury. And it seems to me that that is much more important to attend to that patient, even though the treatment, if you like, carries a risk. And lots of times in medicine, doctors intervene with knowledge that their intervention itself could be harmful. For example, every surgical operation potentially carries a risk with anaesthetic and so on, but doctors intervene because the potential benefit from the patient outweighs those risks. And I think in this case, it sounds to me that this nurse used clinical judgment to do the right thing.
Professor Farrell?
I was just reflecting on what everyone is saying, and I'm thinking about how do we teach our students in sort of medical law and bioethics, when they can often be doctors and nurses themselves, health administrators, as well as young students coming through from their undergraduate law degree. So what do we encourage them to do? We present these sorts of case scenarios to them, and we encourage them to think critically about the stakeholders that are involved, but also approach it from different lenses. Certainly for healthcare professionals and the nurses, there may be professional obligations in that regard. There may be ethical responsibilities. So there's an ethical lens, there's a professional lens, there's a systemic, or I'm going to say structural lens, institutional. And that when we're looking at healthcare, there are moral, legal, regulatory, institutional questions. What makes it sort of complex, fascinating, but also creates vulnerabilities and power asymmetries and decisions that may be a question of the lesser evil. So we need to approach it, I would suggest in that case, is sort of the multidisciplinary approach, appreciating that it is not a one-size-fits-all approach, but particularly in healthcare settings, you cannot ignore the ethical, the moral dimension as well, that need to respond to that patient, but also the safety issue as well, and professional responsibilities. I'm not saying I have all the solutions here, but it's not straightforward, which I'm sure is why you've raised the question.
Well, I just thought that you may give me illumination on the principles and the way in which they might operate in a real life situation. There are lots of different ones, and it arose, as I say, out of the talk there was about systems being designed in places of safety and with leisure but applied in places of danger and risk.
I can just add one small thing, but that I think modelled on aviation, in fact, but there are sort of what you might call decision tree processes for sort of working through the kind of questions we've been discussing about what a reasonable person have done and the sort of considerations that David has done. You know, to get away from the sort of gut reaction of, oh, you know, you've messed up sort of thing, and actually think through quite carefully. So I think they've been very helpful, I think, in giving managers, regulators a sort of way of thinking through these issues to come to what is a more balanced view of the, you know, how somebody behaved. You know, and it takes into account whether people are ill, tired, the circumstances, and so on. But I don't need to go into it any more than that. But it doesn't have to be just, it can be formalised to some extent to help one think through these things.
Sorry, just one thing I wanted to add is that when things go wrong in healthcare, and particularly if there is a patient death, that more often than not, the criminal law may intervene either by way of investigation or prosecution, particularly under English law. And what I've observed as where that particular scenario arises, so say that you've got your patient there as MSRA and passes away in that regard, the criminal law in particular, once it's activated, and it's an important mechanism, you could say more broadly around social control and saying what's wrong and what's right in our society, is that it stops a lot of other processes of learning and investigation around a particular situation. So and that can apply to the clinician, to the family in question. So it's understanding if you're going to engage with legal levers, is there a more joined up approach to learning from that, and which ones do you exercise? And you have to be clear what you're searching for in terms of learning, or are we setting, drawing our line in the sand? But being aware of different legal levers, regulatory levers, and what the potential outcomes are, and they may create perverse disincentives to learning from what went wrong in particular circumstances.
Could I just ask you, was your example a real example?
Yes.
Because that's interesting, because for a while MRSA patients were put together and they would be isolated and separate. So I was curious as to why that.
This is just what happened, but it's and that again may be a system problem in that particular case.
Because they used to put MRSA patients together, or have barrier nursing or separate nursing.
The second question really arises out of what you were asked, Professor Armstrong, by Ms. Richards, in terms of government messaging to the population, where you were asking or saying, well, what if there are divergent views? I mean, how does government put over to the public, well, on one hand, some people are saying this, on the other hand, some people are saying that. In the context of a risk, one group saying there's a real risk, the other group saying, oh, it's not much, is perhaps the first judgment to ask not whether, on balance, you think this view is right or that view is right, but to recognize that on either view there is a risk and something to be debated, and therefore you should take action perhaps in response to a potential risk, without knowing that it's an actual, if there is such a thing as an actual risk, that the risk would eventuate.
Well, two responses. The first is giving the example of CJD, which I mentioned earlier, in which case there were lots of people saying this was a very considerable risk and we should take action against it, which I presume would require banning the consumption of various foods, especially beef-related products. And then there were people who were saying, no, there isn't a risk, this is a theoretical risk, it isn't important. Now, I'm not sure what the action should be there, because there's a range of views, and forbidding anybody to eat beef or whatever, but beef-related products, was quite a severe response to that potential threat. The other thing is, and I heard my colleague speaking, perhaps I want to finesse my response, and that is disinformation circulates, especially in social media, and I think there is a role for government to reject misinformation. So somebody says, if you eat any animal products, you're going to die. Well, the government can say there is no evidence. We've heard nothing in that. There is a debate about whether CJD will spread in the population. We're not, very uncertain about it. We don't know what's happening. You can say that, but at least you can speak against disinformation, which you know to be untrue. And I think there is a role for government to counteract misinformation.
I don't know if any question arises out of those that I've asked.
Not from me, sir, no.
Thank you.
I'm just going to ask if the panel have anything they want to add. I'll just start at this end of the table closest to me and go through. Professor Farrell, was there anything you wish to add?
No, I'm fine.
Professor Pollock?
No, thanks.
No.
No, thank you.
No.
Well, can I, for my part, thank everyone who's been involved with this report. And in particular, let me start with those who aren't here but have contributed to the report, because I think they deserve a public thank you. You'll have seen from the last question that I asked that, in my view, structures or systems have a considerable importance in trying to understand what may have happened and what might happen better. But can I thank Dr. Margaret McCartney, Professor O'Hara, Nicholas Timmins and Professor Walsh, all of whom have played a part in writing this report. And for that matter, draw attention to those who read the report to page 104, which identifies a considerable other list of experts who have, in their various ways, contributed to the product which you have presented on paper. I suspect that Miss Richards could have gone on asking you questions for a third day, and she's nodding, which is because you have made the subject one of real interest in the debate which has taken place, and you haven't been frightened as well, which I very much welcome, to have shades of disagreement amongst you from time to time and have different perspectives. That is highly informative. It's part of the idea of having a question time type of panel, if I can dare describe you like that. But thank you all very much.
Thank you. Thanks to you.
So we're not now sitting tomorrow, obviously, because we're not hearing the evidence from the statistical group. We're resuming on Thursday, and Thursday we will be hearing from 4 parents about their experiences in terms of the treatment of their children at Birmingham Children's Hospital.
So it is Thursday, 10 o'clock.